student-centered, team-based care. So from the authors. So collaborative care team is established using existing school and school system personnel, augmented by organizational partnerships. Example, community behavioral health and pediatric providers, educational and developmental specialists. Now, this can be an important advocacy point because one of the things about the model, at least the way the authors describe it, is we're not talking about mass hiring of new staffing and human and staffing resources, but rather a more organized and efficient use of existing resources and focusing energies on pulling outside school resources into this collaborative care model. Again, not creating these resources, but organizing and creating communication and data, document sharing, organization around these internal and external stakeholders with the school system. So collaborative care team will engage students and families in intervention planning as appropriate. Parent involvement will depend, sorry, W missing there, will depend varying on the student's age, developmental level, and shared determination of need. So, so when possible, the collaborative care model includes engagement of parents and families, and obviously, they're often different. It's not necessarily a mother or father specifically that's providing that family or parental role. So being able to engage the family no matter what their family structure is, and again, depending on the specifics of the student's age, the mental level, and shared interest, the collaborative care model does include engaging the family as part of that integrated network. Collaborative care model also underscores coordinating effective communication along internal and external collaborative care team members. So again, not necessarily having to go and invest a lot of money in creating new resources, just a better organization, more efficient use of existing resources. This also includes, collaborative care also includes identifying needs and tracking internal and external referrals to specialty care, including educational services, social services, and community-based resources. So, so knowing when and where, not just making those referrals outward as needed, but having at least creating a mechanism where some of these other external resources, such as social services, outside education, perhaps private education services like private tutoring, other community-based resources could be, faith community resources, getting them all, if they're part of the fabric of support for that student, that we try to pull them in as best we can and keep a some kind of loop of communication. Routinely check-in process and revising plan is needed. This is something that is somewhat built at least into an IEP model, into maybe a lesser extent of 504 model. But again, formalizing it, maybe having it more frequent, and I would think most importantly, making sure that all those internal and external stakeholders can easily be communicated with and have easy access to kind of centralize what the centralized plan and how that student is performing, how the student is responding to those services, and to the plan and revising it as needed. And along those lines, making sure that we're focused on student, cross-section of student empowerment and accountability. So empowering them to make their own decisions, but also making sure that they're accountable to do the work that's involved, to do the academic work, to participate in health services, as well as making sure that all the above are culturally relevant and are born with the mind of make you know, that stigma may come up, and stigma may be an issue, and stigma may be more of an issue in certain cultures. And so making sure that academic services and health services and the coordination thereof are done with an eye on cultural relevance and stigma mitigation.